entered into the Q&A tool. And without further ado, I'm pleased to introduce our speaker for today's session, What Scale is Best? Understanding Sources of Validity Evidence for Depression Measurement, Dr. Eiko Fried. Dr. Eiko Fried obtained his PhD in clinical psychology in Germany, followed by 4 years of postdoctoral training and methodology in Belgium and the Netherlands. He now works as Professor of Mental Health and Data Science at Leiden University. Eiko's research takes place at the intersection of clinical psychology, psychiatry, and complexity science, and his interests are how to best measure, predict, and understand mental health problems. His lab is currently focused on developing a personalized early warning system for depression. Eiko, thank you so much. We're going to now turn things over to you.
Thank you very much for having me, APA and Chandel. I'm going to share my screen here. All right, I think we're good to go. Yes, thanks for having me. Thanks everybody for being here today. I do want to encourage you to submit questions to this Q&A box because if I talk for 90 minutes, it's going to be a pretty boring 90 minutes. So I plan on answering questions, maybe 20 minutes or let's see how it pans out. But I don't want to speak much more than an hour today. Yeah, I don't want to bore you to death. So that without further ado, I put the slides online. You can see the QR code on your screen. APA will also share that link with you now or later. So the slides will not go anywhere. Yeah, that's it. For learning objectives today, after having seen this 90-minute talk, I would like you to understand the rough concepts of construct validity, and there's many definitions. So today we will work with the 2014 standards for educational and psychological testing. I would love you to recall the 4 sources of validity evidence I used today. Jessica Flake gave a workshop a little while ago who deviated slightly from this list. I use 4 today to make things a little bit more easier because we want to apply them to depression. I would like you to be able to use material to look for validity evidence if you need it for depression, but also other constructs. So I want to make very clear from the beginning that if you are not a depression expert or researcher, but you work on anxiety disorders or, I don't know, personality traits or maybe even intelligence, I hope this talk will also be for you today. And in the optimal case, you're able to give a friend outside of academia a couple of examples why current gold standard depression measurement is pretty problematic today. Thanks also for folks who submitted their questions early on. I sort of integrated them on my slides. The talk today is based in part on a paper we wrote together with my close colleagues and friends, Jessica Flake and Don Robinaugh. And so this is a very abridged version, but goes beyond it with much more recent work. And then, yes, shout out to Jessica Flake's primer on sources of validity evidence that she gave very recently here, also in the same format. I highly recommend checking that out. I want to start with the question why you should care about measurement in general and depression measurement in specific. This is more fun with a live audience in a room, but we'll try it anyway. Try to think along. So I guess many of you will know what this is. This is a little Mars orbiter. I think it spent around 285 days in the cold, dark space between 98 and 99. So I don't know, roughly 10 months or so. And then it crashed into Mars's atmosphere upon arrival because it turned out that the Europeans were calculating in, I don't know how to say this to a partly American audience, but I'm going to say proper units, while the Americans were calculating in freedom units. One crew calculated the travel of the rover or the orbiter to Mars and the other the entrance into the atmosphere, and that didn't work out because measurement is difficult. This is a bridge in the front here between Switzerland and Germany. I think the city is called Laufenburg or Laufenberg. And when they built this bridge in the early 2000s, they built the bridge from both sides, as you do for those sort of bridges. and the Swiss and the Germans together. And the engineers saw that the bridge was around 30 or 40 centimeters. That would be something like 13 inches misaligned. So one side was higher than the other because it turned out that you build bridges above zero sea level, but the Germans were calculating in Amsterdam sea level, and the Swiss were calculated in Geneva sea level, and they're different, oceans, and so different height of zero. This is a funny, well-replicated experiment in psychology where we ask people these three answer options, but we don't give them a question. So all you see is, answer yes, uncertain, or no, and just click the answer or score the answer that you think is whatever aligns with how you feel. So there's no prompt, and predominantly people say yes rather than uncertain or no, again, without any prompt, which is odd because it should be, given that this is a nonsense question, why do people more likely click yes? Same here, people say more satisfied. So second option, although there's no prompt, could also be, is your dog satisfied, right? Same for correct or false, people more likely click correct. And this has been replicated many times. And so why is that the case? There's a lot of things in measurement that we don't understand. This is from my own study. It looks like a lot. I'll talk you along. These are a couple hundred people, in fact, about 1,500 people. So it's a lot of students. And we monitored them over 90 days on the left side and on the right side. And then on the top of each screen, you see kind of green and blue. This is positive affect. And then on the bottom, yellow, blue, and orange, this is negative affect. And you can see positive affect is pretty high, negative affect is pretty low overall. But we found this odd pattern in data. So we measured 4 times a day. This is a very high resolution study. And it turned out that people have much more positive affect and much lower negative affect on the weekends here in the Netherlands, which we didn't really expect. And then on the left side, again, this is more fun in person, but you see a massive effect of the Christmas vacation, positive effect, and then also a very positive effect when the holidays begin in July here in the Netherlands. Again, lots of stuff that you find out via measurement that you weren't really aware of necessarily. I'm going to skip this example. And then this is a fun paper I really like. There's so much drama around social media use, sorry, and social media addiction, and people make all sorts of questionnaires. And so in this paper, folks used a social media addiction scale and simply changed the phrase social media with offline friends or offline friendship, spending time with friends offline. And it turned out that using the same scale, just changing this social media use to offline friendship, about 69% of this sample they used here was classified as having an addiction to their to their offline friendship. So yeah, you should care about measurement because measurement is really difficult, not only in the true sciences, physics, and so on, but also particularly in psychology, where we try to assess internal states of folks. And you should care about depression measurement, no matter if you work with it or not, because it is, I think, the most commonly assessed construct in all of the sciences ever, not just social and clinical sciences. There's a fun paper about the top 100 papers ever cited in all sciences, and 3 of them are rating scales for depression, around rank 50 and 60-ish. So the C is the Hamilton rating scale in the Beck depression inventory. I plotted the citation count on the left side here, so thousands and thousands of citations every year. This is a fun tool that folks published a couple of years back. They looked at 240,000 empirical psychology articles within a couple of years, and they made a website where you can search for words in, for example, abstracts or results. And about 10% of all those papers, not just in clinical psych, contained at least twice the word depression in the results section of the paper. So, a lot of research that isn't on depression also measures depression as covariate, as moderator, as mediator, as a predictor, and so on. Yeah, our ability to measure depression is sort of contingent on doing it well, and that's what the talk is about today. All right. In addition to that, depression is common, debilitating, and often chronic. I assume many of you are from the clinical sciences or the medical sciences today. So I'm not going to belabor this point. There is an agreement that we have had a lack of progress in understanding, predicting, and treating depression. Um, the most common gold standard treatments today that we still do are antidepressants and CBT, and we already did this 35 years ago in pretty much exactly the same fashion. And I believe that our lack of progress in these areas is in part because progress rests on our ability to measure something accurately, and I think we've been slacking a little in this regard. So the third reason why you should care about depression measurement is that measurement may in part be responsible for a lack of research and clinical progress in this area. All right, I will now give a brief primer about the history of the construct. I will do this very, very briefly. I know you're not here for this, but it's very hard to talk about measurement if we don't remember what we measure and where this comes from. This is actually a photo I took of Burton's The Anatomy of Melancholia, I think 1625. I accidentally opened my slideshow in the normal view, not the presenter views, but we're gonna be able to do it. But the presenter notes would say some date. I think it was 1625 anyway. Um, and so we started in 1940s and 50s, where psychoanalytic theory and practice dominated American psychiatry. In the 50s, nearly every US department chair was a outspoken proponent of psychoanalysis. And interestingly, folks in this domain held very negative views about diagnoses. And the patient was considered unique and so on. And if this is your attitude, then of course inter-rater reliability for diagnosis will be hardly above chance because you don't optimize inter-rater reliability based on any criteria. This was considered a problem. Psychiatry should be more closely resembling medicine. And back then, therefore, we introduced a medical model to psychiatry with a focus on more objective signs and symptoms to increase inter-rater reliability. There are a couple of really important papers from this era. One is by Cassidy, 1957, who had about 100 participants sort of looking at their symptoms and what they reported, and 150 here, I think. No, 100 patients, I think predominantly white, or all of them white, I think, and then mostly female. And then there was this famous paper in 1973, I want to say, by Feiner, who wrote down diagnostic criteria for a couple of disorders, including depression, and relied heavily on the Cassidy list from 1957, rather than some other like lists, Hexago and others that existed as well back then. We had the RDC a couple years later, and this led to the DSM-3, to DSM-4, and today DSM-5. And DSM-5 criteria are essentially Cassidy's 1957 list minus constipation. So there have been minor adaptations, but they're very limited. Basically, we have a list that is very similar to Cassidy's 1957 list. Yes. This is a picture of Ken Kendler, who has done a lot of historical work on this. In 1980, Cassidy was interviewed by a journalist and asked why 6 out of 10 symptoms and why 10 symptoms in total and so on. And Cassidy said it sounded about right. I was very upset about this statement when I did my PhD on depression heterogeneity and measurement, but now today I think that's all Cassidy could do. You come up with a list, you do qualitative interviews, you look at a couple of symptoms in patients in sample sizes you can do in 1957, and then you write down those lists and you make an educated guess as a clinician. I take no concern with this today, I have to say. But it's a little weird that the DSM-5 relies on Cassidy's list still. Yeah, today's measurement is very similar to 1957. There are small differences, and we have many measures, about 280 measures for depression. Over 100 are still in use, and all these measures differ in small aspects, assessing frequency versus severity, clinician report versus patient report, focusing on more somatic versus affective symptoms, and so on. But they all assess symptoms, and they all use a sum score as a guideline. So in the end, you will sum up the symptoms, and then you will get a score. We still use the Hamilton rating scale, developed in 1960, in about 90% of all antidepressant trials today. So it's still the gold standard. Um, and Hamilton made the scale before we went to the moon the first time. So a lot of time has passed. And so today, my main thing will be, is our measurement of depression still consistent with what we know about depression, what we have learned in the last 60 years? Are our measures valid? I don't think I'll take questions here because this is really the very rough intro, and I want to get into the measurement part first, but then I'll take a couple minutes for this. We're making good progress. All right, this is Jess Flake and I a couple years ago at the SIPS workshop, I think 2019 maybe in Rotterdam, that we taught. We wanted to make it a teaser photo, and so yeah, we're going to talk about validity and reliability for depression measurement today. Um, if you're interested in this, Jess talked about this more in the last APA workshop. I will do this very briefly. I want to know today if an instrument measures what it purports to measure, which is to me the core definition of validity. And the standards 2014 define validity as the degree to which evidence supports the interpretation and use of a test score for a specific purpose. This is a mouthful, but the question is there evidence for using a test score, not a scale, but the score, like the 14 points on the Hamilton scale or the 27 points on the BDI? Is there evidence that supports the use of the score for a specific purpose, such as diagnosing a person with an episode of MDD, tracking treatment progress over time, estimating the prevalence rate of depression in a given population, and so forth? So these are all specific purposes. And yeah, a scale really needs to be valid for a given purpose before you can use it. And just because the BDI might be valid for tracking treatment progress, treatment progress does not make it valid automatically to estimate prevalence rates, obviously. All right, we're going to talk about content validity first, and then maybe take a little break there. There's a quote here by a famous person, and this famous person wrote, "The appearance of yet another rating scale for measuring symptoms of mental disorder may seem unnecessary, since there are so many already in existence and many of them have been extensively used." Now, would anybody know who wrote this or who said this? Going to give you a couple seconds to think this through. I know you can't really like tell me via voice chat, but maybe some of you can figure it out. I think there's 150, 160 people there. Usually this is a difficult guess, but it is from an author who wrote one of my favorite papers, Hamilton, who wrote the Hamilton rating scale for depression in 1960. This was one of the first and most, I mean, it wasn't one of the first depression scales, but it was one of the first ones that became super, super famous, excessively cited. Again, still the gold standard in pharmacological studies on depression. And I highly recommend you read this paper because Hamilton says in this paper very clearly, don't use the crude total score, aka sum score. Use subscores for different ones. And yeah, Hamilton also says do not use this scale to diagnose people. It is only meant to be used to assess the severity of symptoms in already diagnosed inpatients. Because I, as a psychiatrist working in an inpatient clinic, work with very, very severe depression. Therefore, my scale focuses on very somatic symptoms that are more objective signs than internal states. We have forgotten all of this, and we use the Hamilton all the time for all sorts of things. Basically all papers use the total crude score, as Hamilton would have called it, the sum score, which he expressly said, don't do that. And that's a bit of a problem. Okay. I'm gonna get to that Q&A in a second. All right. This is a paper I wrote, one of the first bigger papers I wrote actually, as a single author, long time ago, 2015 or so. I took the 7 scales that I consider to be the most common used scales in sort of clinical research, including the BDI and the Hamilton and the CESD and so forth. I counted all the symptoms across those scales. There were like 28,000 comparisons, I think. So this was a lot of work back then. And I was very conservative. So if one scale said I am hopeful about the future and the other scale said I'm very pessimistic, I said we're going to call that one single symptom. We're not going to count that twice as separate symptoms. And I identified 52 symptoms for depression in these 7 scales. Of course, there would be many more if you do this for 280 scales. Overlap was pretty low overall. So the overlap coefficient here goes from 0 to 1, the Jacquard index, and it was 0.41. And only 12% of symptoms were available across all the scales, and 40% of symptoms were idiosyncratic. And I think I have a little, yeah. So this is the green dots are symptoms in the CESD, and you can see that the CESD has a lot of symptoms that only appear in the CESD, such as I talked less, people are unfriendly, or people disliked me, which are sort of odd depression symptoms. They were back then, and they are still now today. Um, yeah, so the CESD would not overlap very much with the other scales here. All right, continuing in content validity. So what is the content of these measures? Um, is there evidence that the content of these measures helps us sort of measuring the underlying construct? There was a recent study, again, you can see the links at the bottom of the screen always. There was a recent study in adolescent MDD where they identified 32 trials and 19 different primary outcome measures were used in these 32 trials, which is sort of crazy, actually, if you think about that. In an adult study for adult MDD, they had 450 trials and they identified about 300 different primary and secondary outcome measures, and only 50 of those were used in over 5 trials, which is also crazy. The Hamilton won this competition, was most commonly used again. Yeah, there's a surprising lack of agreement what depression is and how it should be measured, which is a repeating concern today. I didn't actually bother going through the DSM criteria for depression. I would imagine most of you are aware, but I'm just going to do that briefly. So the DSM-5 defines a depression as an episode of lasting for 2 weeks or longer. There's no validation work on this. I'm not aware of any research that tested whether an episode should be 12 days or 16 days or 14 days. 2 weeks has just been chosen because it's an easier number to remember. And there's 9 symptoms, and according to the DSM, you need one of the 2 core symptoms for depression, um, which is sad mood or anhedonia, and then you need a couple more secondary symptoms, such as concentration problems, fatigue, and so forth. All right. Yes. Let me see. I have a couple more things, and then I'm going to look at the Q&A. Where are we here? Yes. So one really interesting study by Astrid Chavons in Paris, 2021, I think, published in Lancet Psychiatry, asked around 3,000 patients, informal caregivers, and healthcare professionals, and not just psychiatrists, but also nurses and so on, what they think should be measured as core outcome domains for depression. It was a qualitative study. We received 8,000 open-ended answers from 52 countries. And this was distilled, doing a lot of work. LLMs were not available back then, so this was all coded by a lot of people by hand. And this resulted in 80 domains that folks thought we should measure. And one of the most interesting findings in the paper is that I think the 5th most commonly mentioned domain by folks is mental pain. And mental pain is in none of the 280 or none of the 50, 60, 70 rating scales that I have used or that I'm aware of. It's not an item ever assessed for depression specifically, although people said it's a very severe concern for them and they would like it to be treated and get better in this domain. This is the resulting graph. It's a little messy because there's 80 features here, but we'll get back to this graph later in other work. Yeah, here actually, this is a follow-up paper by the group of Astrid. Chris Veal wrote this paper as a first author, looking at a couple of hundred clinical trials for depression and bipolar disorder, I think, looking at what scales people used. But then, importantly for this year, they separated them out into clinician-rated and patient-rated scales and assessed to what degree each of these scales measures these 80 domains that we distilled from these 8,000 open text fields. And yeah, you see mental pain here as the last one that is assessed by none of these scales. Yeah, I think this is a really fascinating investigation, and I hope you'll spend some time with it, with these 2 graphs in particular. Wrapping it up here for content validity, I think it's reasonable to say that based on the symptom overlap and lack thereof, that different depression scales do not measure the same construct, which is a big problem because they are used as being interchangeable in the literature. People don't say, we found a correlation between the hippocampal volume and the Beck depression inventory. People say we found a correlation between the hippocampus and depression severity or depression symptoms or depressive episodes, right? But that's just not really correct because the Beck depression inventory in many studies has a correlation with other measures such as the CESD that is substantially lower than 0.5. These correlations are much higher in healthy samples, and they are much, much, much lower down to zero in clinical samples with more variability. This is an interesting phenomenon we discovered a couple of years ago. I guess it's now more known in the literature. Um, I don't want to spend too much time on this, but I'm going to say that if you look at the original scale validation papers in um, uh, for very famous measures, if you look carefully, you will often see that people report Crumbus alpha for the exit measurement point of a clinical trial, and they do not report Crumbus alpha for the entry measurement point because item correlations go up a lot when people get better. And so at the exit measurement point, Crumbus alpha is much higher than at the entry measurement point. And yeah, many scales actually have lower Crumbus alpha. And the same goes here for the scale intercorrelations. If you have a clinical sample and you use the Hamilton and the Beck, at the beginning, they will be correlated 0.3, 0.4, and at the exit, they will often be correlated at 0.7, 0.8. This is not surprising that these scales measure different constructs because they were developed using different theories of what depression is by different scholars for very different purposes. I'm not going to do all of them now, but the Hamilton, again, I already told you, was developed to assess severity in already diagnosed inpatients. Beck scale, on the other hand, which reads very, very differently, was developed by a scholar with a very strong psychotherapeutic background who had very strong thoughts on what depression ought to be that differed dramatically from many other folks at that time. So there's a lot of cognitive symptoms in there, affective symptoms. The CESD was meant as a scale for assessing prevalence rates in general populations. And then the MADRS, for example, for this, they took a battery of, I think, 60 questions. They gave it to folks in a clinical trial, pretty small sample of, I don't know, a couple dozen people. And then they looked which symptoms improved during treatment, and they deleted all the symptoms that didn't improve in treatment. And so this was meant to be a scale sensitive to change. I find the procedure rather questionable, I have to say, but because some symptoms go up, some symptoms go down based on chance. But obviously, these scales don't correlate much with each other, not super surprising. Or if they correlate, they don't correlate much more with each other than, for example, with the neuroticism scale, which is meant to be a personality construct. So, yeah. I'm going to talk about this later, I think. I'm going to skip the last point here. I'm going to talk about this later in a bit more detail. Um, But overall, we have to say that different scales likely measure at least somewhat different constructs, calling into question the use of single scales, which is basically all published studies on depression. Yes, there are a couple of clinical trials that, of course, have a primary and a secondary outcome. But if you look at all the studies using depression as a covariate predictor, mediator, moderator in social psychology and sociology and all these other areas, then of course they all rely on a single scale. Yeah, that's content validity. Let me look at the time. Half an hour, so I think we have plenty of time. And I'm going to look at the Q&A. There's too much for me, I think, to engage with all, so I'm just going to start somewhere. Hi, would it be possible for Eiko to clarify whether correlations between scales are higher at exit rather than entry? Yes, I have a 2016 paper on this, which has the word temporal measurement invariance in the title, so that's not too difficult to find in psych assessment. We described this phenomenon very carefully there, and then my mentor Denny Borsboom back then starts writing the discussion, saying that we have documented a crime, but the suspect is at large, and we actually called on the audience of the paper to help us out why this could be. I think it's partly because of floor effects and ceiling effects. So if a lot of people get very well over the course of a clinical trial, items exhibit floor effects, and there's a certain Goldilocks zone of floor effects where item correlations go up rather than going down, and which is why Chromebox alpha tends to be pretty high at the exit time point. Um, Whereas at the beginning, you have a threshold effect, not really a ceiling effect, but a lot of scores are pretty high because people are selected to have high scores. And then, yeah, you can get in trouble psychometrically as well. Um, there's a question about measures about for children. I am not a child expert or a child measurement expert. We're going to talk about measures, and there's going to be plenty of studies in adolescents also that I cite, and then I hope that'll help you look up more details about those measures. Yeah. Should I run factor analysis on the tool? Factor analysis is one way to look at the dimensionality of a scale. It's pretty well established. I always wonder, so that helps you understand if you're measuring one or multiple constructs, I think. I There's very convincing studies, including the 2016 paper in psych assessment I mentioned, which is our work where we looked at 4 different data sets and 4 different scales. There's very strong evidence that the factor structure is not invariant across time or across data sets or across. Uh, so what I'm trying to say is that if you use a factor model and you apply a factor model to the back depression inventory, and you get 10 or 20 data sets, you will not get the same factor structure in different data sets. Yeah. There's a question about a book. I have not written a book. I have, so the materials include my PowerPoint and my PDF. There's no book. I wish there was a book. Um, is it appropriate to use the same tool to validate challenges of individuals with different disorders? For instance, validating challenges of Africans using scales from America. Yes, I would think so. So I think this is a procedure here, the standards for educational testing that sort of talk through the process of validating a scale, and so I think this is a really good starting point. There's other validity theories and definitions, but I find the standards to be practicable and helpful, so I really like them. If Cassidy scale or admissions are still used in the DSM-5 DR tutor, how can we redefine actually measuring depression? I'm going to get to this later at the end of the talk. And then lastly, is it appropriate to conduct validation studies of depression questionnaires in athlete populations, or are clinical measures alone sufficient? I would definitely see whether a scale and the scale properties translate to certain populations. Athletes are certainly an interesting population because they're more fit. They might have different somatic problems. For example, they might answer questions about fatigue very differently than I, who is not very athletic. And so I would definitely want, in a perfect world, scales to be revalidated when we go to different populations. Okay, I think I'm through for now. Maybe somebody can help me flag those answers as being answered so they pop out. Maybe I can do this myself. Yes, I can do it myself. Bear with me, folks, just a second. Okay. All right. Back to the content. Now I'm going to move on to the second part of the 4 topics of validity theory I wanted to talk about today, which are response processes. Again, this is according to the standards of educational and psychological testing. I really wonder who of you have heard about. I mean, I'm sure there's a couple of measurement pros in the audience who might even more, I mean, probably more about measurement than I do. I'm a dabbler. I also do measurement. But the majority of you, I would bet, has not heard or thought about the term response process very much. There's basically no literature in mental health science on it, which is shocking, I find. And response process is the idea that a score is valid. For example, a patient writing down their own assessment of their fatigue and their sadness, or a clinician writing down SAD score for sleep problems or depressed mood. A score is valid according to this idea that when people respond to an instrument in a way that corresponds to the construct being assessed, and the easiest way to understand this is when somebody does not do that. So this person here is doing a math test and they're clearly not using the construct that we want to measure in a math test, mathematical intelligence, they're cheating by looking at their arm, which is not the response process. So the answer, the test score of this person on this math test will not be a valid response, of course. Hope that makes some sense. Again, there's very little research, but some open questions in our field might be related to response processes. I will talk about this in a second. This is the shortest section of the talk because there's the least research. Here's a couple of phenomena that we need to explain. So a phenomenon is a robust recurrent feature in the world, a replicable thing we have documented many times, but we don't know how to explain yet. When you look at clinical trials over time in systematic reviews, and you compare the pre-post treatment effect. So how much does, I don't know, psychotherapy or psychopharmacology reduce depression severity over time? We find that there's larger improvement in clinician-rated scales than patient-rated scales. There's some work on this that I haven't seen really super well manipulated research. I haven't seen this being done on placebo effects and so forth, but there's some argument to say that clinicians, especially in studies where clinicians are not blind to the treatment, might overestimate treatment effects. I'm a hardcore believer in self-report, I have to say. But yeah, I don't know the truth either, but that's a possibility for sure. And then another phenomenon I find very interesting is that when you take an audience and you assign them 50-50 to do clinician rated scales versus patient rated scales, and it's the same instrument, like the quiz, for example, exists in two versions, or the IDS-2, I think, then usually the clinician rated scores are a little lower than the patient rated scores. And this has many potential explanations. One could be candor. So it could be that folks are less honest in clinician-rated situations. You have to remember that a lot of clinical trials do not happen with your therapist. They happen with some random person on the phone that you've never talked to, and maybe even with a robot. And so there might be a lack of candor, for example. Again, these effects are not very strong, but they're certainly replicable in there. And I think they're interesting and related to response processes. I have friends working in the VA in the US with veterans, and we see that some of these scores are very high on trauma. And I've heard some of my colleagues there say that these scores might be so high not only because trauma rates are pretty high, but also because the response process some of the participants using is not what is my trauma level, but I need help. And the VA is the only way to get help in this country at the moment for me with my financial means. And therefore, I will click the maximum on all the buttons in this test, which is not what we try to measure, but it is a different response process, basically. And then the last one I wanted to mention here, sorry for going back and forth there, is impairment. The DSM, in addition to the 9 symptoms and 2 weeks, requires a person to experience sort of impairment of functioning in multiple domains of living, or at least one domain of living, I don't know, social, occupational, and so forth. Basically, none of the most commonly used rating scales take this into account. And then you need to take into account things like I'm not sleeping well in the last 6 weeks. I've had a really bad time. And then in one case, I have no reason to give. I just, I wake up at night, it's really bad, and then I start ruminating. And in the other case, I have construction outside of my building and it's very noisy. And of course, a clinician can take this into account when scoring insomnia as a part of depression, yes or no. But in a patient-rated scale, the patient will not take into account the construction causing the insomnia. So these are all really interesting, I think, aspects of response processes and might explain why we see some differences. This is a very recent study. I'm not going to talk that much in detail about studies today, but I find this study really interesting. JAMA Psychiatry actually ended up publishing a measurement paper we wrote which is very, very rare measurement stuff is very hard to publish in clinical journals, especially high impact. So we're kind of proud. And so I wanted to talk about it very briefly here. This is the two first questions of the PHQ. Today, I would say the most rated, the most used scale, in part because yeah, it's free for use, and that's why people use it. The PHQ basically assesses the DSM criteria, pretty verbatim. And I show you the PHQ instructions here, which have always bothered me, pun intended, because it asks over the last 2 weeks, how often have we been bothered by any of the following problems? But then people answer the frequency of the problems. So the question is, how often have you been bothered? Which means it assesses the frequency of having been bothered. So it doesn't assess severity, it doesn't assess frequency or bothered by, it assesses the combination of frequency and bothered by, which I find pretty cognitively demanding, actually. And because it bothered us, we ran, this is the paper read by Margarita Panayotou. We ran with data of Zach Cohen, who's the last author on the paper. We ran two groups of participants through a small experiment, one 500 people general population sample and one 350 people clinical sample. First, we gave them a hypothetical scenario. We said, imagine you're on vacation, you oversleep a lot. You oversleep 14, 15 hours a night for like 3, 4, 5 days. But it doesn't bother you. There's no impairments. You enjoy it. You love sleeping 14, 15 hours. Sorry, first we gave them the PHQ. Then we gave them the scenario, and then only 55% in the general population and only 60% in the clinical sample interpreted the PHQ as instructed, which means they should click 0 for sleep problems. It didn't bother them at all because, again, the PHQ asked how much did it bother you, and our scenario said it doesn't bother you. Then we asked them whether they had completed the prior PHQ based on whether it had bothered them, the frequency of symptoms, or if they took both into account. And only 21% and 12% of the two samples interpreted the instructions correctly of the PHQ. And then we asked the same for the future. And again, only a minority of participants reported interpreting the instructions correctly. And most strikingly, we find in the paper that some people who answered, or people who answered the PHQ in a certain way, had lower overall PHQ scores. So people's interpretation of the PHQ instructions appear to have an impact on the severity that you get from the scale, which is not great. This is a small study. This is preliminary, but we wanted to sort of put attention on this, and this is better done in cognitive interviews rather than what we did here in a survey, of course. So if you have the money and the resources, please qualitative interviews on this would be very much appreciated. All right, I'm going to sip my coffee and go back to the questions for a moment here. What is your take on dynamic fit indices in psychometric assessment? Yes, it's a great question. Trying to find my phone to look at the time. So factor models and other structural equation models are used in psychometric assessment, and you get fit of these models based on thresholds that people found in papers 25 years ago. The Hu and Bentler paper is often cited, which says that this score, this parameter or fit index needs to be this and so forth. But it makes very little sense for a 7-factor model that you find to use a threshold for RMSEA that was established based on a 1-factor model, And so the idea of dynamic fit indices uses simulation-based approaches to solve that problem, and I highly recommend you use those. They're not that difficult to use anymore. There's great software. Dan McNeish has worked on those, and then there's much other work too. And so, yeah, highly recommended to use dynamic fit indices whenever possible and available for you. All right, these are response processes. We're going to go to internal structure now, the third aspect of validity evidence. Thank you for Shandel for removing the question already. Internal structure, that's the most complicated one when I explain it, but it'll become clear in a second. Internal structure is the extent to which relationships among test items, so depression symptoms, are consistent with which one's theory about the construct being assessed. The problem here is we don't have much theories. When I ask people what depression is, they give me the DSM criteria for depression. But that is not a theory, that is an operationalization. The DSM says here's how you measure depression, but it doesn't tell me what depression is. So, Beck had an idea, Aaron Beck had an idea what depression is. He has a theory of depression. But other than that, I mean, yeah, so it's hard to do this sort of work, given that measurement is largely theory free. When you look at any given paper, they say we use the CESD. They don't tell you why. They don't tell you what their definition of depression is, other than what scale they used, which is not the same kind of question. It's a bit like asking what temperature is, and somebody says, my thermometer is temperature. It's like, nope, that's how you measure temperature. Temperature is a lot more than your thermometer. And so instead, what we do here in the paper is we assess tacit assumptions present in research practices. I'm going to give you a couple examples. The first one is taxonicity. Um, so so much work in our field is based on case control studies where we take people with depression and people without, and we compare them on genes or brains or hormones or personality traits. That means we have a depressed group and a control group. Top right shows you how the sum score should look like if such a case control study would be a sensible way to study the world. The DSM criteria are similar. We have major depression and we have healthy. Now we have minor depression too, but we will ignore this for the sake of the argument. But yes, the world is a bit more complicated. Overall, a lot of research in our field, I don't know if researchers believe that, but a lot of research in our field assumes that depression is taxonic or categorical. Top right, again, there's a zone of rarity in the middle. Some diseases are taxonic. Measles, for example. Nobody has a third measles or two-thirds measles. You have measles or you are healthy. Yes, you can have some degree of severity in measles, but cases are on the left, measles are on the right, and there's nothing in between. Now, if we look at data for depression, it either looks like the middle, so this is a bit of a subclinical sample, or it looks like at the bottom. This is more common in general population samples. And now I colored in blue where the threshold for depression is, but there's absolutely no statistical argument to draw the line there specifically, rather than a little bit further left or a little bit further right. This also explains why so many thresholds for clinical depression exist. There's this beautiful paper by Glashinsky where they had 350 clinical trials using the MADRS scale, and these studies used 28 different thresholds ranging from 5 to 34 points, and something similar has been found for adolescent major depression, which I have below, which is a real problem. But it makes sense. God did not make a threshold where healthy becomes ill. And so we are all dabbling here and using all sorts of thresholds to try to make sense of this. My own perspective is this year. I'm much more interested if depression is taxonic within person. So these are made up data now. The x-axis is time. The y-axis is depression severity, the number of symptoms. And I simulated a couple of healthy participants. You can see the start. So this is, I think, how the time series of many of us looks like. There's days that are a little worse. There's days that are a little better. Overall, we go back to normal. People differ in their height. And now I simulated a couple of people with depression. So these are people who get depressed. I'm not saying this is how the world looks like. All you clinicians in the audience have your own ideas if this is true or not. But I think this is taxonic in a way I find interesting within person over time. Is depression a state that is taxonic within person? I don't care too much about between person structure, to be honest. I think that's not how the world works. Mental disorders are dynamic over time. Okay, second assumption, and then we'll do Q&A again. Hope you didn't fall asleep yet back home. Internal structure, it's tough talking about psychometrics and making it interesting, but we're trying here. Unidimensionality. All of you who have used depression measures in your papers usually report a total score or a sum score. And that's okay. I have done the same. But of course, this total score is based on the assumption that all the items contribute roughly equally to the total score. Yeah. So from a factor modeling perspective, you assume that roughly that the factor loadings are roughly equal, not exactly, but roughly equal, right? And of course, this is not true. So suicidal ideation, for example, usually has a much lower factor loading. So has fatigue, for example. Also, usually we don't even get one factor from depression data, especially in clinical samples, not just healthy samples. Going back to what I said before, we get 3, 4, 5, 6, 7, 8 factors, and the factor structure is not consistent across time in the same data set, across data sets with the same measure, or across different measures. So it's very, very messy. Um, I think I'm gonna, yeah. Yeah, so using this unweighted sum score implies that symptoms are interchangeable. Again, this is just not the case based on evidence. It's also not the case given that individual symptoms differ in many different ways. Suicidal ideation is not the same kind of thing as fatigue or depressed mood or weight gain or weight loss. And the clinicians in the audience know this, of course. You deal with these issues in different ways. And we also have a nice review paper showing that different symptoms have different risk factors, different symptoms impair functioning in different ways. There's different biological markers for different symptoms, and so they are literally not interchangeable. And you can do a sum score. The sum score will still provide you some level of information on how badly off some person is. More symptoms is usually a bad kind of thing, but you can certainly not say that 13 points on the BDI are the same thing for Bob, are the same thing as 13 points on the BDI for Susan, given that 13 points can mean so many different things. 13 points can mean Susan has the worst symptoms, extremely impairing, high suicidal ideation, really bad prognosis. And 13 symptoms for 13 points for Bob can simply mean he has like 1 out of 4 in all the symptoms. He has a little bit of everything, but he's doing all right. He goes to work. He has maintains his relationship. So it's just good to be aware of that. Right, that severely limits the validity of a single score to denote one underlying construct in depression measurement, and we should be very careful for these single scores. All right, let me look at the Q&A for a second there. Oh no, I lost my window. Here we go. Can you talk about the dimensionality aspect from the network psychometric lens? Yes, maybe before I move on to the next point, I'm going to talk about this. This is a good question. Thank you for pointing this out. So in network psychometrics is a statistical approach, but the statistical approach is based on the idea, the theoretical approach, that there isn't a latent construct depression that causes all symptoms, but that symptoms are causal agents that interact with each other. So the relationship between fatigue and insomnia doesn't come from the fact that your hippocampus or whatever causes fatigue and insomnia, but that when people don't sleep very well, they're also going to be tired the next day, which is kind of obvious. And so this has led to network psychometric methods. And in the case of unidimensionality, I have to say I have written quite a few of these papers using these network methods. These network methods are also estimating correlations among items in the same way that a factor model would estimate correlations among items. So it's really statistically not all that different. But I have been asked in all of my papers using network methods to report Cronbach's alpha for my scales that I used, which is hilarious because Cronbach's alpha is, in a traditional psychometric perspective, considered to be a good value when it's high, right? So you want a high Cronbach's alpha. Why is that? A high Cronbach's alpha means all items are correlated extremely highly, which means they all measure the same latent variable. That's why we consider a high Cronbach's alpha a good thing. If Cronbach's alpha is 1, it means you can reduce the scale to a single item, and the single item is good enough to capture all the other items in the construct. You no longer need the other items, right? Not that this is possible, but that's the idea of Cronbach's alpha. But from a network psychometrics perspective, there's no reason to assume that we want a high Cronbach's alpha at all. And so I usually sort of push back to editors and reviewers when they wanted me to talk about chromos alpha, because there's nothing good about high item correlations from a network psychometric perspective, where each symptom is its own thing and they don't assess an underlying construct. Yeah, thanks for the question. This was not a paid actor, I have to say. I love talking about network psychometrics. I appreciate the question. All right, inter-rater reliability. This is a tough one. I will say to all the clinicians in the audience and all of the folks running clinical trials that overall, basically our entire field in clinical practice and medical practice uses one diagnosis of one single person to assess whether somebody's depressed, which means whether they get healthcare access, whether they can enroll in a clinical trial, and so forth. This practice of assigning a single diagnosis by a single rater implies that we believe as a field that diagnoses are reliable, that individual raters can reliably assess whether somebody's depressed. And many of you will know this, but for those who don't, I'm sorry to say that this is not at all the case, and there's basically no evidence for this whatsoever. Um, yeah, let's go through the evidence. So kappa in statistics is a way to assess how consistent different raters score the same 0-1 diagnosis. Um, Kappa ranges from 0, which is chance level, to 1, perfect agreement between two raters. There are studies with kappa values over 0.9, which is exceedingly high. If you talk to the investigators of those studies, they tell you, yes, yes, we had one interviewer rating the patient in a conversation, and the second rater sat in the second room and rated the same interview, or they watched a videotape and rated the same interview, which is not how this should work. This is not a valid way to do inter-rater reliability. If there are studies that have real two separate assessments in two separate conversations with structured interviews, which are rare in the world, which leads to kappa values of around 0.6. Unstructured interviews, which are the most common way that this is done in medical and clinical practice, lead to kappa values around 0.3. The DSM field trials had a kappa value of 0.28, which I would call abysmal. They call it sufficient, I think, or maybe questionable, but it really is very low. And I think it was the lowest um, kappa value for any of the larger, more common DSM disorders. Again, for comparison, bipolar disorder and PTSD have more than twice as high kappa values. And studies that look at kappa values in general practitioners, which again, I think 85, 90% of all diagnoses of depression in the US are given by GPs, not by psychiatrists. There you are basically at chance level, which is a super severe problem because obviously both overdiagnosis and underdiagnosis are very, very problematic for numerous reasons here. So this is a very, very problematic state of affairs. Um, we have actually a little figure in our paper to showcase how bad the problem is. This is a simulation based on 100 participants with a prevalence rate of 30%. So around 70% of people, or 70 little Bobs or Susans here don't have depression. This is the true state of things, and 30 have depression. And with the DSM-5 field trial kappa of 0.28, you can see that the green ones are assessed correctly, where both raters agree. The blue ones are assessed incorrectly, where one rater gives the wrong answer. And the golden ones are cases where both raters give the wrong answer, which is really, really common on the right side for does have depression. So this should really worry us, I think. All right. Keep those questions coming, folks. Otherwise, I'll be talking for 90 minutes and nobody wants that. Um, Last issues before we go to the ways forward on solutions. I mentioned some of those already in very briefly. There's a study looking at, they actually had 2,500 clinical trials that they used, but I like the MADRS result the most because it resulted in 28 different thresholds ranging from 5 to 34. Yeah, this seems like a very severe problem. because we can't agree what a diagnosis of depression means for enrollment of participants into a study, but also what remission means, because these thresholds are also used not only for determining the severity to get into a study, but also the threshold required you need to drop under when you are no longer depressed. And again, the 5 to 35, that you can multiply the value 5 by a large number and still stay under 34. So that there's multiple, I mean, it's not quite an order of magnitude, but basically an order of magnitude difference, which is problematic. The other example of 9029 trials for adolescent depression identified 47 unique definitions of remission, which is crazy given that there's more definitions of remission than studies in here, or trials in here, I should say. And then this is something I wanted to mention before, and I foreshadowed already. Observer-rated scales such as the Beck Depression Inventory, such as the Hamilton Inventory, are much more common in pharmacological trials than psychotherapy trials, which more rely on the Beck Depression Inventory, for example. And interestingly, those observer-rated scales that are more common in antidepressant studies, for example, are more likely to yield larger pre-post effect sizes than self-report scales. But that's a really big problem. Antidepressant trials use observer-rated scales more commonly. Psychotherapeutic trials use patient-rated scales, and there is a fundamental bias in that observer-rated scales have larger effect sizes. So this means we overestimate antidepressant efficacy and underestimate psychotherapy efficacy in systematic reviews. And I'm not aware of a way to correct for this. Yeah, another really big issue. Question time. Why are GPs chosen for diagnosing depression if people in the psych field, clinicians, are more optimal choice? I am German, living in the Netherlands. I lived in the US 3 times, but I don't feel comfortable speaking to the sort of healthcare deficit situation there. I think my guess would be that GPs are diagnosing depression more often than experts trained in psychiatry or clinical psychology, because the first person you go to is a GP, usually. That there's a service problem probably in many countries, including the US. And so the most common person diagnosing you will be your family doctor. I don't know if fortunately or unfortunately, from an inter-rater reliability perspective, certainly unfortunately, because they're not as well trained as other folks, of course. All right. Jennifer asks, this might be an unclear question, but I'm trying to build a self-efficacy scale for GTAs, and I want to also assess how depression affects self-efficacy in teaching. Is there a way I can give 2 assessments and then compare the two? I think I understand the question as written, but I'm not sure if I get what you're getting at there. I'm going to read it one more time. I mean, I think I would maybe look at 2 or 3 depression scales, Jennifer, and that capture different aspects of the space you're interested in, that are valid in the situation you're working on. I don't know, like school children, or I don't know, very intelligent people or athletes. And then I would give them a self-efficacy scale, and then I would indeed look how these scales relate to each other. And there's psychologists think of this as a nomological network. How's my target construct related to other constructs? Maybe that helps a little bit. I'm not sure. Do you recommend a particular measure with the least limitations for MDD? I actually have a slide on this, Brian, at the end. Yeah, happy to get to this a little later. A small follow-up question: should GPs be trained for measuring depression more accurately? Yeah, I would love that. So there's real strong evidence that structured interviews lead to higher inter-rater reliability than unstructured interviews. Again, the 1960s psychoanalysts would say that's a problem. Structured interviews are also a problem because you assess a pre-selected list of problems that is very short, that doesn't capture the person's actual problem. So I'm not of this tradition, but I could certainly see that asking 9 questions would not do justice to the 80 outcome domains that were identified in the work we did with Astrid Chavons and Harris. certainly structured interviews help increasing interpreter reliability. If this increases validity or not is something I'm not really confident to answer at this point. Sorry. All right. All right, I'm going to get to the last question. Oh, there's one more. Since the factor structure of a scale might change based on different data sets, um, and as they were created using old fit indices cutoffs, should we validate them in every sample we take? Yeah, I would love if people using a psychometric scale that is important to them for a given study would report the means of every item and maybe alpha and omega and a bit of psychometrics along. In my warranty study, 2,000 people assessed over 2 years with many, many repeated measures. We're currently finishing up a project where we have 800 items in, I don't know, 50, 60, 70 measures. And I'm currently finishing up a project and a paper with two PhD students who recently graduated, um, Adam Kolchak and Anna Panseri, where we build a website and all the psychometrics of all the scales are going to be on the website for this particular project so that people can look at our data, but they don't even need to look at our data to look at the psychometrics of neuroticism in Dutch students or at the psychometrics of the PHQ-9 over time over 2 years. And I think if we all got better in sharing information on the scales we used and the psychometric properties, and we provide a statistical tool that people can use in this paper, I think we would all be able to learn a lot more because we could properly meta-analyze the scales across many, many different, the scale properties across data sets. But yeah, this is not the case right now. Thanks for the question. Thanks for the questions, guys. This is much more fun. I have 20 more minutes. I'm going to do two more questions to make sure I can wrap this up. My understanding of the Hamilton scale is that items are weighted differently for heavy emphasis on the core symptoms. Yes, so this is really interesting, Stephanie. The Hamilton is one of the very few scales in existence that has items from 1 to 3 and items from 1 to 5. And Hamilton assigned items from 1 to 5 more range and more weight because he thought they should weigh more heavily, and then you do a sum score. You're completely correct. This is extremely unusual and psychometrically a disaster because, of course, 5-point items have very different properties. You can use polychoric correlations pretty easily with 5 points, but with 3 points, 3-point items, polychorics get into cell count problems often, even in larger samples. And so, yeah, it's a bit of a nightmare. But sure, if we believe that Hamilton knew what he was doing, you can use the Hamilton, which weighs items a little bit more than other depression scales, 100%. Do you have any resource that guide measurement practitioners on how to conduct all aspects of item analysis, like a step-by-step again? There's tons of free books on this. I have a blog post on this using basic psychometrics. And Nuka, if you send me an email afterwards, I'm happy to share that blog post. You can find it on eiko-fried.com. And then if you look for psychometrics, there's going to be, it's 3 or 4 years old, where I have R code and I show basically my own analysis that I go through in any single thing that I want to learn a little bit more about. Okay, lastly, I'm a bit concerned about response process when it comes to pilot testing, especially on intervention and placebo. Want the response from the control group affect the outcome of the experimental group? Sure, I think so. I'm not a expert in qualitative interviews or cognitive interviews. I think it's very important we do this more, but there's tons of research, and I'm not yeah, I'm not knowledgeable enough to get into the weeds of qualitative interviews. Certainly there's reactivity, and we got to be careful about that for sure. Thanks for the question, Nanda. All right, conclusion. We defined validity as the degree to which evidence supports the interpretation and use of a test score for a specific purpose. Existing validity evidence does not support many common uses of depression measurement instruments, including diagnosis and evaluating treatments over time. How to move forward? Well, first of all, this is psychometric stuff, and it comes from the ivory tower. I'm a researcher. obviously we need to measure depression severity. Personally, I would be just as happy if clinical trials for depression used impairment measures, functioning measures as primary outcomes, because there's tons of evidence. There's a great paper by McKnight and Casht in 2008, for example, that functional recovery often lags behind symptom recovery by up to 6 months. And we shouldn't consider people healthy after a treatment when they still have severe functioning impairment. There's a couple of cool trials happening in Norway right now where the primary outcome measure for depression is if people are able to pick up work again. So these are people with unemployments, who are unemployed, and the main goal of the treatment itself is getting people back into work consistently. And so one way is to sort of sidestep this problem here by using just different types of outcome measures, in my opinion, that I care more about than symptom recovery, to be honest. But that's a separate topic. One solution that has been quite common is mandating measures. So I think the Wellcome Trust and the NIMH, a couple of years back, 2021, wrote a blog post which became a paper where they said you must from now on for depression use the PHQ-9 or we will not fund you. I have huge respect for NIMH and Wellcome and the people working there. I also have many friends and colleagues there, but I think this is a very terrible decision. Together with Pravitha Patali, we wrote a sort of rebuttal to this in an editorial perspective, talking about reasons why this is a pretty bad idea. You can read it. I'm just going to do the very brief summary here, oopsie, which is that the PHQ has not evidenced transferability across settings and purposes. Again, a scale needs to be valid for a given purpose. And the PHQ has not been shown to be valid for, I don't know, diagnosis or tracking treatment in athletes over time or whatever. Same with community and clinic and settings. It narrows the scope of inquiry. The PHQ-9 has 9 symptoms. There are so many more that matter to patients and clinicians. And just because Cassidy wrote a list of a couple of symptoms in 1957 is no sufficient reason to limit our inquiry to these 9 symptoms today, in my opinion. I always learn from clinicians in this regard, so feel free to put something in chat also. Be curious what you think, but clearly, especially also given the high comorbidity rates with anxiety problems, this is just not sufficient. It also lowers the evidence for robust evidence because, in my opinion, to showcase that, I don't know, psychedelics are have massive treatment efficacy for depression or treatment-resistant depression. I would love for folks to have to use 2 or 3 different measures of depression rather than one that is sort of placed on a pedestal for random reasons. So if your treatment outperforms your placebo group and you show this in 3 different measures of depression that are have low correlation with each other, consider me convinced. In terms of measurement anyway. So I think I would much rather use multiple bad measures than one bad measure. I'm gonna skip the last one. So instead, let's use a wider set of measures that have been validated for specific populations and research purposes. Let's fund measurement research. And again, Wellcome Trust has done this also. Recently, Astrid Chevance and Caroline Krause in Paris got a fairly sizable measurement grant on building a living evidence synthesis website or platform for researchers, patients, and so forth for the PHQ and a couple of the other scales that were mandated, the GAD, the HUDAS, and I forgot the 4th one. So that's really great, and I'm helping with this effort also. And then also let's stress limitations of mandated measures to avoid application, replacement of measures across studies and health systems. Also, while I take my last sip of coffee, it's really important that we understand why we are where we are today. And in the paper I showed in the very beginning, which is also titled about the shaky foundations, we discuss methodological and theoretical foundations that are really shaky for depression in specific. On the methodological side, scale development, there's many lists. This is a very basic, easy list, but I think it's appropriate for here for getting the big picture idea. Scale development basically has 4 steps. First, you explore the substance of the construct. You can think of Cassidy's 1957 paper as something like this, right? He looked at people, it was fairly qualitative. Clinicians were involved, and we sort of like walked around the construct and we tried to describe it carefully. Um, yeah. Then you explore the statistical structure of the construct using psychometrics or other tools. Then you look at the nomological network. So you explore the relations between the construct and I think maybe Jennifer was the name in the chat, who wrote about self-efficacy. So what is the relation between depression and anxiety, neuroticism, self-efficacy, gender, and so forth. And then each phase, in the best case, includes iteration and yeah, updates until the desired outcome. This is what we ought to do. What we have done so far is we largely skipped step one, at least in the last 50 years. We did phases 2 and 3. There's basically no iteration. I studied this stuff pretty carefully. I'm only aware of the BDI having received updates. I know that versions exist for some of these scales, like the Hamilton has a 7 item and a whatever 24 item version, but they're not updates on the 21 on the oh, sorry, on the 17 item Hamilton version. There's not no updates. And I would love if you make a scale, please, please, please call it scale 1.0, put it on GitHub or put it on the Open Science Framework, and make sure that people can find in 6 years when they look at your scale from the original scale validation paper, a website that then has the scale version 2.3 or scale version 8.4, because no scale is good at the beginning of scale validation. Even version 1.0 requires many updates. And two other problems are that scales have been constructed largely atheoretical without stakeholder involvement, which we're trying to change at the moment a little bit. Now, for the theoretical foundations, this is such a kind of silly, easy sentence to write, but for me, it really changed how I think about measurement. This is from the paper. Without a clear theory of depression, it is unclear what researchers aim to measure and how we can evaluate whether they have succeeded. I think this goes back to the question somebody asked before. Aiko, what scale would you recommend I use? Well, what is depression for you? Because only when what you tell me what depression is, what you think depression is, can I then look at a measure and evaluate whether you have succeeded in applying this measure to assess your construct. And if your idea is depression is the DSM-5, then the PHQ-9 is probably pretty okay because other than missing out on impairment, it does pretty well in faithfully assessing the 9 symptoms of the DSM-5. For example, I don't think the DSM-5 is a theory of depression, but um, if all you want is measuring depression as written down in the DSM-5, the PHQ will do okay. There are many tacit beliefs embedded in instruments that do not align well with decades of research, such as the taxonicity assumptions, for example. And there's this beautiful paper by Snaith in 1993, concluding that the measurement of depression is as confused as the basic construct of the state itself, which has not changed, arguably, in the last, again, 40 or 50 years. Ways forward, there's this beautiful book by Hazok Chang called Inventing Temperature, who I highly recommend it to everybody if you're interested in measurement at all, who talks about this process that took hundreds of years where people were aware of a construct in the world, temperature, but they had no measure for it. And it took hundreds of years to build thermostats. So he talks about standards kept by each workman without any agreement or reference to one another. And in our paper, we discuss or we argue that the pressure measurement is basically 17th century thermometry. There's multiple thermometers and thermostats. Everything is different. Everybody works on their own little thing. Everybody agreed there is something like depression or mood disorders, but the precise nature is unclear. And in Hazok Chang's book, he talks about epistemic iteration as a way forward, where we have a really bad theory and then we make a really bad measure, and the really bad measure informs us about the state of the world to update our theory to make it slightly better, sorry, and then we make a slightly better measure, and it takes 400 years, and then we had a thermometer. and that's how things probably work. And we have not iterated in our field since the 50s or 60s. DSM-5 is based on Cassidy's 1957. This is the opposite of iteration, and it's a problem. So concretely, we need theories because we cannot divorce our measures of depression from our theories about what depression is. This also applies for other constructs, of course. Current measures are atheoretical, but infused with some theories, such as that the item correlation should be high. I mean, we drop symptoms from rating scales for depression because it decreases Crumbus alpha, or it increases Crumbus alpha to drop these items. But there's so many assumptions behind that that we should be really aware of when we make scales. Yeah, I will skip my own thoughts on this. I have my own little theory of depression. It's probably not a good one, but it is a theory of depression. It has to do with the idea that we should look at within-person processes more than anything else. I want to know whether depression is continuous or categorical within person. Is it for most people a big black wave falling over people, as some of your clients have definitely described it as? Is it a slow process for some people? For whom is it slow? For whom is it fast? Yeah, these are all sort of aspects of complexity science. I want to study social determinants. Again, going back to the US, there are so many people who are unhoused and unemployed, suffering from severe mental health problems. They don't need psychotherapy. They need a house and a shower and a job, right? So there's so many social determinants that explain so much variance on depression, but they're nowhere to be seen in the DSM. So what is the role of these social determinants outside the person? But yeah, this is a new paper published very recently. Feel free to read it and criticize it because that's what we should do with theories. And then we need iterative measurement development. Again, I talked about this already. I very much doubt Hamilton would be happy to learn that we use this scale unchanged and unaltered 60 years later. It's kind of crazy, actually. I think he would think that is a bad thing, not a good thing. And again, I think that Astrid Gemon's work on these 80 domains is a really good start because it takes experiences of stakeholders into account, which includes very much nurses and lived experience experts, partners of people with mental health problems and so forth. I think this is something where we have not done enough work. And then I'm gonna, I think, stop it here. Our paper has a table on how to improve measurement. I'm not going to go through this in detail here, but I talked about some of this epistemic iteration, robustness checks, and so forth. You can find this in the paper. I think it might be paywalled. Please reach out to me if you can't access it. Otherwise, on icofreed.com, my website, I also have all the PDFs of all my work, including the paywall stuff, because in the Netherlands you can do that, unfortunately. So you can find the things there as well. Yeah. And now I think this was a question in the chat. Ico, what depression scale should I use? I think that might have been Brian. I'm not sure anymore. But yeah, it depends on what you want to measure, and then make sure to pick something that is valid for your purpose. We still have a couple of minutes. I'm going to do maybe one or two more questions, and I think then there's also a final APA announcement before we leave. But I wanted to thank Jess Flake and Don Robino, and then of course Ken Kendler also in APA. I'm going to go back here so you guys can find the QR code for the slides if you want, while I look at the last few questions here. What do you think about the clinical value of progress monitoring measures to track symptoms? I think the sort of ROM, routine outcome monitoring literature, has the same problems and strengths, and I think we should totally do measurement-based care. And I'm very happy to track progress. It's better to do it at all than not at all. So I think this is a great approach, but these measures certainly have the same issues as to what we've discussed today, Brian, at least in my opinion. Um, how can we redefine depression, measuring depression? In my paper, in our paper, we end the paper with, I don't know, 500 words on how we would do that, based on our theory. I believe depression is an attractor state. I believe people are stuck in a vicious cycle of problems that is hard to escape, and getting better from this perspective doesn't mean getting fewer symptoms, but reducing the attractorness of the state. So there's these gravity wells in physics. Every planet has a gravity well, sort of the depth of the attractor state or the angle of the attractor state. And there's lots of nice research from the 80s and 90s on network destabilization, the idea that we need to break these vicious cycles so people can be enabled to jump out of these attractor states back to a healthy attractor. But that's my theory, and I would build measures accordingly to this, which would not feature a lot of symptoms, to be honest. They would feature information about dynamical systems and whether people get lost in this attractor or not. But that might not be for everybody. But I believe that. So um, measurement has to be based on theories. Um, can you suggest some courses on scale development? Not from the top of my head, sorry. There's a couple of free ebooks on psychometrics. I would probably start there. If measures are not perfect, is it better to examine specific symptoms rather than relying on a total score? 100%. This is also one of the 8 or 9 points in the screenshot I showed before that we highlight at the end of the paper. I think we call it symptomics in the paper. I'm a big fan of assessing individual symptoms. I think that's it. I'm gonna say thank you to APA and Chandler and all the others and you all for being here with me today. Slides are online. I'm gonna give the microphone back to Chandler. Thanks, folks.
Aiko, thank you so much. What a wonderful presentation. And thanks to everyone for sending in such thoughtful questions. It really was a great interaction. So we appreciate everyone who joined us today. We hope you enjoyed the training. The session was recorded. You should receive a link to the recording in about 2 to 3 weeks. And you will also receive a 1-minute survey to complete after today's broadcast. We value your feedback. Many of our topics come straight from that survey. So please let us know what you want to learn about. You can also email us at science@apa.org with recommendations. And again, we hope that you'll subscribe to Science Spotlight, a free newsletter, and it's your source for the most relevant news, information for psychological scientists, opportunities for funding, and other resources and events. We hope to see you at future events. Thank you so much and have a wonderful day.